This endocrine lecture is going to look at nursing situations for clients with disorders of the anterior pituitary, and then also with those clients that have issues with diabetes insipidus. Remember, the pituitary gland has two lobes. It has an anterior and a posterior lobe. Both of these have different functions and secrete different hormones. The anterior lobe secretes follicle-stimulating hormone, luteinizing hormone, adrenocorticotropic hormone, thyroid-stimulating hormone, growth hormone, and also prolactin. The posterior lobe secretes antidiuretic hormone and oxytocin. So any altered function can lead to a hypo or hypersecretion of one or more of the hormones that are listed there on the slide. When we look at disorders of the pituitary gland, some common causes that can cause these disorders include pituitary tumors or hyperplasia. This is found commonly in adults. It's equal between men and women. Typically, that's a benign type of a cancer, and the most common symptoms seen are headaches and visual changes, and that's due to pressure that the tumor is putting on the optic nerve and the brain. So those are the symptoms that those patients have. Typically about 70 to 90% of the anterior pituitary gland is going to be damaged before the patient is going to actually have clinical symptoms develop that will bring them to their primary care provider. Our nursing situation is looking at a 40-year-old woman who's been referred to the endocrine clinic by her PCP, and the assessment findings indicate that she has bilateral hemaniopsia, which we're going to talk about in a later slide. She also has headaches, amenorrhea, lethargy, polyuria, and polydipsia. So with this particular patient, more than likely she's going to have a CT scan or an MRI to confirm the suspected diagnosis of a pituitary tumor, and also a battery of laboratory tests to confirm this diagnosis. Remember that interaction between the pituitary and the kidneys. Remember that anterior pituitary secretes ACTH, which then goes to that adrenal cortex, and the adrenal cortex is the one that secretes the mineralocorticoids, glucocorticoids, and the androgens. And we talked about that in the last lecture with the Addison's disease. So the pituitary can affect the adrenal and also vice versa. Just remember that relationship as you start to think about this particular endocrine disorder. Remember the anterior pituitary gland hormones we talked about a little bit earlier in the lecture. But when we think about growth hormone, if there would be a tumor that would cause increases in growth hormone levels, this can result in abnormal growth patterns. We see in children, it's called gigantism, and in adults you might see that referred to as acromegaly. Patients that have problems with prolactin secreting tumors, this can result in excessive breast development in men, known as gynecomastia, and also inappropriate milk production in women, galactorrhea, and probably prolactin secreting tumors account for about 30% of all pituitary tumors. So as you can see, the tumor may not cause increases in all of the hormones, but may only cause increases in certain hormone levels and those types of things. If the patient's problem is with ACTH, that's going to stimulate the adrenal cortex to secrete too much mineralocorticoid and glucocorticoid. And if the problem is in the TSH hormone, then it's going to cause the thyroid to increase secretion of the T4 levels and those types of things. If the problem is with the gonadotropins and those hormone levels get too elevated, then there's going to be problems with ovarian and testicular function, which can result in problems such as menstrual disturbances, infertility, and those types of things. So please see that pituitary tumors can cause oversecretions of hormones. Your book also refers to the fact that sometimes a tumor could cause hypofunction of the pituitary gland. And in this case, you would start to see certain types of the glands that these hormones target will then start to atrophy and those types of things. So refer to your textbook. It gives a lot more detail in this area. Some good calls for nursing for these clients include anxiety, pain, risk for self-esteem issues and disturbance, sexual dysfunction issues, and risk for activity intolerance related to what's going on with the hormone levels within their body. In our patient scenario, we're going to say that the patient had an MRI. It did come back and confirm that that patient did have a macroadenoma of the anterior pituitary gland. So the physician advised that the patient see a neurologist to have a transsphenoidal hypophysectomy done. This would be done by a neurosurgery with a neurosurgeon. And what actually happens with this picture depicts the actual surgery that goes on. It's done typically with microsurgery, and it removes the tumor while preserving as much of the normal pituitary gland tissue as possible. So typically the surgeon will go in through the nose through a small incision, or it can also be done at the junction of like the gum and the upper lip on the inside of the mouth. So it's really surgeon's preference as far as how they want to access and get up to that area of where the tumor is. Once that tumor is removed, to prevent leakage of cerebral spinal fluid after the surgery, where the dura mater has been actually tapped into to get to that area of the brain, there's going to be a patch that'll be put over that dura mater by a piece of tissue from the leg typically. Typically, if they go in through the nose, it's going to be packed, and the gauze dressing is going to be worn under that nose to absorb any drainage and to keep that packing in place. So excellent results from this surgery. About 90% of patients are cured after this surgery. The most common complication that's seen is that patient can develop diabetes insipidus, and that's because as the surgeon is removing the tumor from the anterior pituitary, sometimes the posterior pituitary also gets disturbed. It may have trauma to that posterior pituitary, which then causes the hormone levels from that posterior pituitary to start to be off. So preoperatively, teaching would include, first of all, answers about the disease and the actual surgical procedure, give emotional support, let that patient know that they're going to have lots of nasal packing in place and some sort of a nasal sling, which is not very comfortable to have all that packing in place. Typically, it's in place for about 24 to 48 hours up to a few days, depending on the patient's scenario and surgeon preference. So during all this, because of that nasal packing, the patient will need to mouth breathe, which is an uncomfortable situation, makes the oral mucosa very dry. Patients are encouraged not to sneeze, but if they do, it'll be through the mouth area. And the patients will need to be on post-op IV cortisol because of the pituitary, anterior pituitary being operated on and those types of things. So many post-op complications. The patient could go into Addison's crisis, could have I&O imbalance problems, could have the risk of increased ICP, intracranial pressure, fever. They could have cerebral spinal fluid leak, the risk of meningitis due to operating in that area of the brain. So many different post-op complications that those patients could develop. Other post-op nursing interventions include to monitor for signs and symptoms of a potential increased ICP. And if that happens, the patient will typically have an elevated blood pressure and a widened pulse pressure. What that means is the systolic pressure is typically elevated, where the diastolic remains relatively stable, which leads to that widened pulse pressure. So normal pulse pressure is about 30 to 40 millimeters of mercury. Think of like 120/80 and the difference between those two, whereas you're going to see that number grow larger with the patient that has increased ICP. Patient will typically have, if they also have increased ICP, they'll have bradycardia, start to see pupil changes and altered respiratory patterns. To prevent ICP, typically we want to put these patients in a semi-Fowler positions. They will need the head of the bed elevated for 2 weeks after surgery just because of the risk of ICP. And we want to encourage these patients not to cough, sneeze, blow their nose. And so that they don't have vomiting, which would increase ICP, we will give them antiemetics to take if they do feel nauseated. Other post-op responses include to watch for signs and symptoms of meningitis. So if that patient develops a fever, severe headache, irritability, nuchal rigidity, which is rigid area of the neck, we would worry about that patient developing meningitis, and then obviously they'd need treated with appropriate antibiotics. So another thing we worry about is if that patient develops a leak around that patch that was put on the dura mater or on the brain. So anytime they would have a runny nose, feel like they're having a postnasal drip, a stiff neck, persistent headache, those types of things, the patient should be examined to see if perhaps they are developing a cerebral spinal fluid leak. Other signs and symptoms of infection to watch for: the patient will not be able to brush their teeth if they went in through that gum incision line for about 2 weeks afterwards, until that incision is well healed. So typically they're just going to be doing mouth rinsing and not actual toothbrushing, because they don't want to have any injury done to that surgical area in there. Also, the other things we talked about, since they're going to be mouth breathing, we want to keep the lips moist and lubricated, gentle mouth rinsing, encourage fluids, and after that packing is removed, we're going to check for rhinorrhea and postnasal drip. If while they have that packing in place, the nurse would happen to note a halo ring on that gauze sling that's with the packing, that will appear as a yellow halo around serous fluid. That could indicate that the patient has a cerebral spinal fluid leak, and that would be something that would need to be reported to the physician. Typically this will test positive for glucose, this halo fluid that you see, if it is positive for CSF. So we've already talked about the issues of not having that patient sneeze, cough, bend forward, and they may be on prophylactic antibiotics. Typically these patients have a nasal swab done before they have this surgery done, just to make sure that they don't have anything infective in their nasal passages or a sinus infection or anything like that. Post-op nursing responses include to prevent atelectasis, so we're going to turn them every 2 hours. We will do deep breathing exercises on these patients, and incentive spirometer. You should not be having the patient cough, so up there where it says cough and deep breathe, you would not want to cough. You would only want to have the patient deep breathe, because coughing would actually increase the intracranial pressure. So we do instead sighing and mouth breathing to help to increase that lung expansion and those types of things. Preoperatively, those patients would be given medications such as cortisol, and then postoperatively they're going to get lifelong hormone replacements of cortisol and any of the other hormones that they may be low on because of the tumor removal. Also, they may find that their replacement therapy needs to be tripled or doubled in times of stress, surgery, infection, or those types of things. These patients will have lab studies done about 4 to 6 weeks after the surgery to look at all the different hormone levels produced by the pituitary, and then depending on the values of those labs, they'll decide which medications the patient needs to be on to replace lab or hormone levels that may be low for them. In our case scenario, we're going to say that the surgery was successful for our patient. However, 10 hours post-op, this patient is developing a postnasal drip and frequent swallowing. So what do you think is going on with this patient? If you think that the patient may be having a CSF leak, then you are correct. So we would want to assess drainage in the throat with a flashlight, check that external nasal packing for that halo ring we talked about earlier. Check vital signs to make sure that patient isn't developing increased ICP changes. Keep that patient on bed rest with the head of the bed elevated, and also assess for signs and symptoms of infection, meningitis symptoms such as fever, headache, nuchal rigidity, and those types of things. So if the patient is developing an infection, they will be put on an antibiotic and a bed rest during the initial treatment. So the patient also begins to present with low blood pressure, a little bit of a tachycardia, respirations are okay. The patient is complaining of being very thirsty, the skin is flushed, and you note on the patient's Foley urometer that the patients had 300 milliliters per hour of a urine output with a specific gravity of 1003. The patient's muscle tone appears very flaccid. So the additional information that you need to see is on the next slide. We need to check and see what that patient's temp is, look at the neurostatus, if the patient's dehydrated, restless, irritable, other signs of hypovolemia that patient may have, such as dry skin turgor, INO imbalances, mucous membrane changes, and all those different types of things. So we would need to look at those as far as what's going on. So remember that patient's specific gravity was very, very low. A typical urine specific gravity is going to be like 1.010 to 1.020. So it shows that that patient is putting out very, very dilute urine. So what actually is happening with this patient is she is developing diabetes insipidus, and that's because her posterior pituitary was probably injured in the surgery that was done to remove the tumor from the anterior pituitary. So when this happens, the patient will not produce sufficient antidiuretic hormone, which causes these patients to lose huge volumes of urine. And what this does is, because of this large amount of very dilute urine that they lose, these patients become very hypovolemic and very dehydrated very, very quickly. So diabetes insipidus is not the same disease as diabetes mellitus. They are two totally different things. So you need to look at your textbook to look at the differences between those. With this large volume of urine, sometimes these patients will put up to 12 liters per day as a urine output because of that very, very low amount of antidiuretic hormone that those patients have because of the surgical manipulation of the pituitary gland. Typically, this will be seen in the first 24 hours after surgery, if the patient's going to have this complication. But it can be caused from other things. It's not just because a patient has had surgery on the pituitary gland. Sometimes we'll see this particular diabetes insipidus disorder from our patients that have had multiple trauma to the head, cerebral edema, or different things like that. So nursing responses for diabetes insipidus are obviously to really keep a close eye on that intake and output, do daily weights on these patients. Physician needs to be notified if that urine output does get above 200 milliliters per hour, especially with a low specific gravity, because that patient's going to need the IV fluids increased. Typically, we'll give a hypotonic type of a solution, like maybe 0.45 normal saline would be a good example, up to 3 liters per day, and also to give ADH back to that patient. So antidiuretic hormone could be given in the form of vasopressin, which we can give sub-Q, IM, or IV. It also does come in a nasal format, but for our particular patient case scenario, since she has nasal packing in place, this would not be appropriate for her. So we go ahead and notify the physician of what's going on with that urine output. So we get some orders to monitor the serum and urine osmolarity and the electrolyte values, and get orders for the IV to be increased up to 3 liters per day, and to go ahead and have an order for vasopressin to be given, IM, sub-Q, or IV. So with these patients, the book talks a little bit about normal values for serum osmolarity. Typically are around 280 to 300 milliosmoles, and with these patients we typically think that when we get values back, you're probably going to see their urine osmolarities are going to be very low, but their serum osmolarities are going to be very high, and that's just because they're losing so much fluid. Typically they talk about if you would do a fluid deprivation test on these patients, within about an 8 to 12 hour period, they would probably lose up to 5% of their body weight. So in other words, if you had a patient that weighed about 175 pounds, that patient would lose almost 9 pounds in an 8 to 12 hour period just of fluid alone. So 1 pound of body weight equals about 500 milliliters of fluid loss. So It shows you how quickly these patients can become severely dehydrated. Some expected positive outcomes that we would like to see on this patient would include that the vital signs would start to stable out, the patient's INO would become balanced, electrolytes would be within normals, patient would have moist mucous membranes, good skin turgor, not be thirsty anymore, and the patient would be alert and oriented times 3. So once we get that patient's hydration status stabilized, hopefully these would be the outcomes that we would see in our patient. Discharge teaching would include to let that patient know that replacement therapy is going to be needed for life for whatever hormones the lab values indicate are low for that particular patient. Many times it may be the glucocorticoid and mineralocorticoids. That patient may need to be on vasopressin for some time period or for life, depending on how much that posterior pituitary was affected. And the patient may also need thyroid or sex hormones, depending on how many of those pituitary lab values come back low. This is just one quick slide. I wanted to give just a little bit of information about sudden inappropriate antidiuretic hormone and or syndrome of inappropriate antidiuretic hormone. This is actually the effects you see on the patient are going to be the opposite of the patient that has diabetes insipidus. With this particular syndrome, the client retains fluids, the patient has hyponatremia, and particular common causes you see of this are head injury, bronchogenic cancers, severe pneumonia, brain tumors or infections. Certain medications can cause this. And the way that we treat it, because these patients have too much fluid on board, is we actually do fluid restrictions and Lasix. So your book gives further information on this particular syndrome, so you can take a look at those readings. And the reason I wanted to put a slide in on it is because you may have a patient when you rotate back to the ICU, if they're in with head injury or other types of problems, you may see that the patient has developed SIADH. So I wanted you to know what that particular acronym stood for and the signs and symptoms that you would see with these patients. This particular NCLEX question looks at a patient who's admitted for surgery to treat a pituitary adenoma, and to minimize the risk of post-op respiratory complications, the nurse would focus the client's pre-op teaching on the importance of which of the following. So remember, the correct answer is going to be we're going to have that patient deep breathe, but we're not going to have that patient do any coughing because that would actually increase ICP. So preoperatively, we'd want to let the patient know that we really don't want them to do a lot of coughing or straining or those types of things post-op. And for nausea, remember we talked about we would give them antiemetics so that they don't increase the ICP by having vomiting and that type of thing. And this concludes the lecture on disorders of the anterior pituitary and diabetes insipidus.